Hello everyone, today we are reviewing the coronary angiography and interventional management of 46-year-old patient who presented with a history of hypertension and diabetes mellitus, both significant risk factors for coronary artery disease. In the initial angiographic views of the left coronary system, the proximal of LCX appears markedly ectatic. At the first glance, there seems to be a significant stenosis distal to the ectatic segment. However, after careful comparison with the distal reference vessel diameter, it becomes evident that this lesion is not hemodynamically significant, and therefore medically management is the most appropriate strategy. Next, in the array cranial view, which represented the most diagnostic and critical projection in this patient, a severe high-risk stenosis in the LAD is clearly identified. This lesion carries a substantial risk and, if left untreated, could have resulted in myocardial infarction. In the same projection, the diagonal branch demonstrated diffuse disease without a focal target lesion, making optimal medical therapy the preferred treatment approach. In the spider view, the osteoma of LAD has a lesion. However, given the mild degree of stenosis and the fact that a stent deployment in this area would require extension into the left main coronary artery, which is associated with increased procedural risk, and medical therapy was again favored. After completing the assessment of the left coronary system, we proceed with right coronary artery injection. The initial angiographic views demonstrate multiple mild stenosis along with ectatic segments, all of which are suitable for medical management. In a subsequent view, the PLV branch is noted to be significantly ectatic. Following a comprehensive anatomical assessment and treatment planning, the decision was made to proceed with a PCI targeting the critical LAD lesion, and the interventional equipment was promptly prepared. To enhance guide catheter stability and facilitate the procedure, the LCX was wired first, followed by wiring of LAD. Using the same wire, the lesion length was accurately assessed. Subsequently, predilation of the stenotic segment was performed using an appropriately sized balloon. This step was repeated multiple times to improve coronary blood flow and adequately prepare the lesion for optimal stent delivery. Next, a properly sized stent was deployed across the lesion and inflated. In a post-deployment contrast injection, the vessel demonstrates excellent luminal expansion. To ensure optimal stent position to the vessel wall, post-dilation was performed, following the standard technique previously discussed in the earlier videos. We are now going to review the post-dilation ballooning technique. In the final angiographic image, the LED is widely patent with significantly improved coronary follow, which can be clearly compared with the pre-intervention image. Thank you for your attention.